I got into an accident, God willing I don't, on the way home, and went to an emergency room nearby and was not conscious, I would not be able to tell the attending physicians that I'm asthmatic. And I've had some difficulty in reaction to anesthesia. One time I was under anesthesia a few years ago for a sinus operation. So it's possible that there would be erroneous care given to me because I wouldn't have the ability to articulate my medical history, and because that hospital would not have my medical history in all likelihood in front of them. The obvious solution is to create as quickly as we can a seamless, accessible, and accurate system of medical records where ideally every provider in every situation would have access to those records. It would improve the quality of care, reduce error, and be a good idea. Almost everybody agrees with that. There's some dispute about how to accomplish that, but almost everyone agrees with that proposition. It also will accomplish very, very little in reducing the cost of health care across the economy. It'll do some good, but anybody who holds the proposition that that alone is sufficient to solve this problem is really not looking at the data or the evidence. The second idea that's talked about a lot is wellness, is promoting better health practices by men and women and children in our country. I think this is indisputably true. I think if we smoked less, ate less, exercised more, adopted other practices, we'd be healthier as a country. One compelling statistic is that if the percentage of Americans who are morbidly obese was today what it was 15 years ago, outlays in the healthcare system would be $1 trillion less than they are today. The cost of dealing with juvenile diabetes, with other factors associated with that and other conditions and diseases is very significant. And I think you'd find almost no one who would say that promoting different choices by people is a very intelligent choice for us to make in legislation. But you know, there's some creative tension in all of that as well. What exactly does that mean? One could look at the two extremes and say, well, the one extreme is to pass laws that require people to change their habits. We could ban cigarette smoking, as we did with alcohol in the early part of the 20th century. We could ban certain high saturated fat foods, as there have been some jurisdictions have done. Or we could take the other position and say that education, voluntary cooperation would be the best way to accomplish this. The discussions in Washington have generally taken the middle ground on this and talked about economic incentives and disincentives to encourage healthier healthcare choices, along with education. One major difference between the House and Senate bills is whether or not insurance companies can discriminate on the basis of premiums and deductibles for smoking. The House bill says they can't. The House bill says that when insurance companies fix insurance premiums, they cannot discriminate on the basis of any behavioral practice or medical condition at all. The Senate bill, on the other hand, says that there can be up to a 50% premium discount and or penalty if someone smokes. That a smoker could wind up paying considerably more in premiums and deductibles versus someone who does not. This is a very controversial provision. Oddly enough, the American Cancer Society opposes the provision. Their view is that it would be punitive to people that have chosen to smoke. A lot of other people believe it's the right thing to do. It's the one sort of economic idea that would push people toward wellness. The second, less explicit idea, but I think no doubt less compelling, is the structure of insurance policies for the newly insured. It's anticipated that these newly insured people would get insurance policies that have very heavy insurance for preventive care, very low copays, very few deductibles to go for an annual checkup or immunizations or things of that nature, and very, very high levels of insurance for catastrophic care. So if one has a heart attack or a stroke or is in need of an expensive procedure, that would be almost completely covered by insurance, but a lot of deductibles and copays in the middle. And the idea here is that those who make healthier choices are less likely to incur those higher copays and deductibles and this would be yet another economic incentive or disincentive. Now, medical records and wellness, you can get almost everyone, from Senator McConnell on the one end to Senator Boxer on the other end, to agree that these are good ideas. The other four ideas take you into much deeper and rockier water. The third idea is that we should change the delivery system by which hospitals and doctors and other healthcare practices deliver healthcare to our people. That we should switch from a system where the quantity of procedures one does is replaced by a system where the emphasis is on the quality of the outcome that one achieves. This makes an awful lot of sense to me. If you and I each operated an MRI center, and today my MRI center did 1,000 procedures and yours did 500 procedures, I would make more money from the Medicare system than you would. But if your MRI center identified 99.9% of the cancers early on and did a great job at saving people's lives, and mine identified 94% of the malignant tumors early on, I'd still make more money than you do, because the payment system is based upon the quantity of procedures that we do in Medicare and not the quality of the outcome. Another very significant example of this is work that Dartmouth, I'm sorry to mention a rival, an inferior to Princeton obviously, that Dartmouth has done, is in the field of hospital readmission. Dartmouth estimates that Medicare will spend this year about $15 billion to pay the hospital bills of people who were discharged from the hospital and then readmitted into the same hospital within 30 days of the discharge. Dartmouth has concluded that about 2/3 of these readmissions were preventable had there been the right care in the first place. So if you do the quick math, it's about a $10 billion a year outlay in a $400 billion program. It's put it in perspective, but about a $10 billion outlay that could have been avoided by better care in the first place. So what do we do? What are discussions about this? The House bill and the Senate bill change the Medicare payment rules to encourage better practices that would avoid hospital readmission, to encourage higher quality outcomes for MRI centers, and other such ideas. The idea is not simply to reduce the outlays that we spend for Medicare, but to change the delivery systems, both in the public and private sectors across the board. This has taken on the unfortunate label of a, quote, Medicare cut. And so conservative Republicans who for years have been saying that restraining entitlement spending is absolutely necessary to right our fiscal house are now saying this is not what they meant. That when they talked about restraining the growth of Medicare, this is not what they were talking about. We're going to give them an opportunity next Thursday to say exactly what they were talking about, since this is the way we think that you can restrain Medicare and Medicaid outlays. So there's a lot of controversy over that idea to reduce costs. The next idea to reduce costs that you hear about is tort reform. And it frankly has become a sort of viral, popular message that instead of a comprehensive reform of our healthcare system, we should simply pass laws that say that the amount you can recover if a doctor malpractices you is fixed and limited by law, that this would be a miraculous breakthrough that would reduce the cost of defensive medicine. And of course, the argument is that there are numerous procedures that are ordered by doctors and hospitals and other providers that are not necessary medically, but that are designed to cover their defenses against a potential liability suit, and that the defensive medicine costs could be avoided in this way to reduce healthcare costs. I'm not doctrinaire in being opposed to this idea. I'm not one who would say, oh, this is a terrible idea, we shouldn't consider it. In fact, I think we should take a look at it. But I also think we should also take a look at the evidence. Texas has had a statute almost identical to what I just said since 1998. Texas in 1998 passed a statute that put rather low limitations on how much a successful plaintiff could recover from a defendant in a medical malpractice lawsuit. It's been on the books now for a dozen years. What's happened to health care costs in Texas? Well, nationally, increases in healthcare insurance premiums have been 11.7% per year in the past decade. 11.7% per year. In Texas, they've been lower. They've been 11.4% per year. It's frankly been a statistically insignificant difference in health insurance costs. If you look at healthcare outlays, money spent by hospitals, doctors, and other practitioners, there's been a slightly lower rate of growth in Texas than the rest of the country, but not much. But not much. The Congressional Budget Office did an exhaustive study of this issue about 5 years ago. They are regarded, I think, as a nonpartisan source of research, and they reached the conclusion that the reduction in healthcare outlays because of tort recovery limitations would be a very minimal, would have a very minimal impact on healthcare outlays. But I'm open to evidence if it would suggest it would take us in a different direction. That's the fourth idea. The fifth one is more competition among insurers. I'm all for that. This has somehow morphed into the discussion of competition across state lines. So the sort of rallying cry of the Republicans has become the way we will control costs is to have tort reform, like I just described, and we'll let people buy insurance across state lines. There's a couple of problems with that. If buying insurance across state lines means that the seller will only be licensed in the state, in one state that he or she finds most attractive, what you will in effect do is delegate to that state legislature the national standard for consumer protection. So there are states in this country that don't require a health insurance company to pay for a mammogram. They don't require a health insurance company to pay for a stay in the hospital after a C-section birth beyond 48 hours. What you would be doing here if you simply had competition across state lines is creating a sort of race to the bottom, as whichever state had the least protective, or depending on your point of view, intrusive consumer protections would be the one where most insurance companies would flock to incorporate and be organized in that way. Now, the House and Senate bills do provide for interstate competition. They provide, in fact, for the creation of a national interstate marketplace called an exchange. The Senate does it state by state, the House does it in a national marketplace, but the basic principle is the same, that uninsured people and those working for small businesses could buy insurance through these marketplaces, which are not state by state, and that sellers could sell through these marketplaces by qualifying with the rules and regulations to get into that marketplace. A lot of this discussion, though, I think misses the main point, which is why competition doesn't work today. It isn't that big of a deal for Anthem, Blue Cross, and Blue Shield, for example, to establish a subsidiary in New Jersey and start competing with Horizon or start competing with AmeriHealth or others in this marketplace. That Blue Cross has some of their own rules. Hi, Rush. Blue Cross has some of their own rules, by the way, but it wouldn't be that difficult for them to do such a thing. Why don't they do it? Well, the reason is that you can't compete in a marketplace that's outside of your own if you can't build a provider network. Well, let's say that Congressman Holt and I lost our senses and decided to try to form a health insurance company today to go compete in another state. We would walk into that state and get licensed pretty quickly. It's not that expensive or difficult to do, but here's the reality that we face. When we went to enroll our subscribers in the hospitals and other providers of that new state, they would not give us the discounts that they give the incumbent providers. Because the incumbent providers, the incumbent insurance companies, have hundreds of thousands or even millions of covered lives. So they naturally get a volume discount for their business. We would not enjoy such discounts because we'd have zero covered lives to start out with. So our first liability is that we'd have to pay the hospitals and doctors more than our competitors are doing. Our second problem, of course, is that in order to attract business as a new name in the marketplace, we presumably would have to offer a lower premium. If we're going to take business away from the incumbents in the marketplace, we're going to have to offer a lower premium, a lower price than those against whom we're competing. So we would have this double whammy of having to pay our hospitals and doctors a higher fee to see our patients, but collecting a lower premium from our customers in order to get there. Now, if you have very deep pockets, and if you have a long time, you might be able to survive such a situation. You might be able to carry that loss for a number of years and sustain yourself, and then win market share in the way that I just described. However, there is one other caveat to this. The natural reaction of the incumbent insurance company in that market is going to be predatory pricing. They're going to come in and go even lower than you would offer because they want to scare you and chase you out of the marketplace. Now, if you were selling cereal or automobiles or houses, that would be illegal because predatory pricing is prohibited under the terms of the federal antitrust statutes. Those statutes do not apply to the insurance industry. So predatory pricing practices by the incumbent companies would be quite legal, and they would step in and do such a thing. And so the idea of competition across state lines, I think, has some merit. It's something we need to look at, but we need to understand it's not a panacea because of the problem of building a provider network and because of the problem of the race to the bottom in consumer protections of which I spoke. Now, so those are the first 5 ideas to cut costs, right? There's medical records. Everybody seems to agree with that. There's wellness. You know, subject to how that's implemented, people seem to be pretty comfortable with it. There's the idea of changing the delivery system to encourage better practices to avoid hospital readmissions or a better batting average with MRIs. People say they agree with that until they have to vote for the Medicare funding changes that it actually entails. Congressman Holt did vote for that. He will be attacked for, quote, cutting Medicare as a result. It's a nonsensical argument, but there's not quite the degree of unanimity there is on that one. The fourth idea is tort reform. Again, I'm willing to understand that there is defensive medicine in the system, and wringing it out would be a good thing. I happen to think the claims are exaggerated, and I'd like to see the evidence which shows that they're not being exaggerated, but it's something we have to take a look at. The fifth idea is promoting more competition among insurers. By the way, in the House bill, we did that by ensuring that every person eventually would have the right to choose a Medicare-type plan in competition with the private providers, the so-called public option, which we felt was the most powerful way to induce real competition. The Senate did not do that. Instead, it has a provision where, in effect, certain private plans will be given national charters to go in and compete in any market along certain lines. That's the way they do that. Now, the sixth idea, and I think it's where the rubber really meets the road, I think it's what really separates us from the Republicans, is we believe that covering everyone is also essential to getting costs under control. And we have some company in this. Here's what Senator McConnell said in August. He was asked, can the problem be solved by leaving nearly 50 million people uninsured? Here's what he said. Well, the uninsured don't go without health care. It's not the most efficient way to provide it. As we know, the doctors and hospitals are sworn to provide health care. We all agree it is not the most efficient way to provide health care, to find somebody only in the emergency room and then pass those costs on to those who are paying for the insurance. So it is important, I think, to reduce the number of uninsured. The question is, what is the best way to do that? Mitch McConnell, actually July of 2009 of last year. That is exactly the question. What is the best way to do that? And to walk you through the options for this, I think that there's grounds for a lot more agreement if the other side is prepared to accept the reality of their own statements. First way to get everyone covered is the single-payer system. Put everyone under Medicare. We can debate the merits or demerits of that. The reality is the votes are not there to do that, and that's not one of the options that would be viable to pass. Second way to do this would be to abolish the employer-based system, which frankly Senator McCain essentially proposed in his presidential campaign. And Congressman Ryan, who's the leading spokesman for the Republicans in the House on this, has more or less proposed as well, that instead of our employers providing us with health care, we'd all sort of get a health care Pell Grant, depending upon our income. Those with a high income wouldn't get one at all, but they could deduct the cost of the premiums they pay from their taxes. And those with a lower income would get a subsidy and would also get the right to deduct what came out of their pocket. And we'd all go out and buy health care the way we buy auto insurance. And we'd all sort of be out left to fend for ourselves with the health care companies to see what would work best. That's an option I don't think will work, because I think that what happens is people lose the value of their combined purchasing power that they get through their employers, and I don't think it will work, nor do probably 3/4 of members of Congress. Most Republicans don't agree with that idea. So where we are is where we are, which is to take the existing system, which has public programs and an employer-based system, and build on it, which is what both sides say they want to do. Now, to build on it, you divide the employer world into three pieces. You have employers that are too small to cover people, and you subsidize those employers. You have employers that are large enough to cover people but choose not to, and you mandate those employers to cover their employees. And then you have employers who are already covering their employees, and you essentially leave them alone. One of the questions that's been asked about the House bill for a year, and Rush can tell you this too, is why don't you just take the 15% who are uninsured and help them, and then leave the 85% who are insured alone? Well, that's what the bill does. Essentially, that's what the bill does. It takes the 85% of Americans not on Medicare or so that are uninsured and helps them purchase insurance through a system of subsidies. It helps small businesses buy insurance for their employees, and to the larger businesses that are already insuring their employees, it essentially leaves them alone. It does subject them over an 8-year period to some new standards, like not letting insurers discriminate on the basis of pre-existing conditions. Lets them phase into that. But that's what it does. So I'll stop in a minute, but this is the debate that's going to take place, I hope, next Thursday. It wasn't President Obama who said that doing nothing is not an option. It wasn't me, it wasn't Rush Holt, it was Mitch McConnell who said that. That if we just do nothing, that things are going to get out of control and get a lot worse. Well, the issue on the table will be, what should we do? How do you control costs? Everyone says you can control them by getting better medical records. Let's do that. But let's not delude ourselves into thinking that that's a major solution to such a large problem. Almost everyone says that encouraging wellness would help us reduce costs over the long run because people would be healthier. Let's do that. Let's try to do it in a way that takes into account the difference between a behavioral choice and a pre-existing condition. I think a very important distinction that's more than just semantic. Almost everyone says that changing the delivery system so that hospitals that don't have a lot of unjustified readmissions get an incentive to do that, and hospitals that do have a lot of unjustified readmissions have a disincentive against doing that. We voted for that. Frankly, that position has since been mischaracterized as a reduction in benefits for Medicare recipients. If people are serious about doing this, let's do it. Let's work together and figure out a way to do it. The fourth idea is tort reform. Again, I'm driven by the evidence. I'd like to see the evidence that would show that there would be a meaningful reduction in costs, but I would be open to some sort of tort reform if that happens, because it's something I think we should take a look at. The fifth idea is more competition. Okay, I'm all for that. I think there should be a maximum degree of competition in the health insurance industry. But simply saying that people can sell from one state into the other is not going to accomplish that. Without a meaningful way to help new entrants in the marketplace build provider networks, you're not going to have the benefits of market competition. What you're really going to do is just drive up oligopolistic or even monopolistic profits. And the sixth issue, I think, is the most important one. Senator McConnell seems to say that he thinks that covering a lot more people, we would say everyone, is not just essential as a moral proposition, but is essential as an economic proposition to bring this cost control problem to a solution. We do need to have an honest debate about how to do that. We've laid out our ideas. Expanding the public programs like Medicaid and S-CHIP, helping very small businesses buy insurance for their employees, requiring larger businesses to do so, that choose not to do so, and then essentially getting out of the way of the large majority of American employers who already do what it is we say that we want them to do. That's our answer. And I'm looking forward next Thursday to a full, vigorous, and public discussion of what the alternatives are. I don't think we have all the answers. I don't think our plan is perfect or obviously better in every way than someone else's, but I think this. And it's not just what I think, it's what the Congressional Budget Office has determined, that over the 2-decade window they've looked at, that this plan will significantly reduce costs in the healthcare economy. Their estimate is somewhere between 0.5% and 1% of GDP, which in today's terms would be between $70 and $140 billion. Our plan reduced the federal deficit in the first 10 years by $110 billion, and in the next 10 years by a number significantly greater than that. Our plan covers 37 million people who don't have health insurance today, and I believe does so in a way with minimal disruption to people who are happy with the coverage that they have. So we've put a set of alternatives on the table and put it up for a vote and passed it. I do think the burden will be on those who claim to have the same goals to meet the same burden of proof next Thursday. We look forward to it. I think the President deserves credit for having such an important discussion in such a public forum. And we look forward to the results. Now, I did want to more formally recognize my friend and colleague, Rush Holt, for coming in. He's serves on our Education Labor Committee that is writing this legislation. He has been an invaluable asset, as you would well expect. And I'm delighted he came today. So thank you. I would be happy to answer any questions, even from Rush. Yes, yes, sir. He's wrong. The HIPAA statute, which was enacted in, I think, 2000 in the main, says that your medical records can't be shared without your consent, which is a good idea. The solution's rather easy. You would sign a document that says that I am hereby authorizing any hospital or medical practice that meets the following protection standards for my records to have my records, period. The problem is not a legal impediment to sharing your records. The problem is this. If you and I were cardiologists and we wanted to tap into this system, we'd have to spend money on hardware and software. It doesn't make any sense for us to do that because most of the people whose records would be in the system we would never see as a patient, so we'd be expending our own resources for no good whatsoever. In the Recovery Act, which passed last year, there was an answer to that, which says that if our cardiology practice made the investment in the hardware and software which would make us eligible to get these patient records, we'd have a slight jump in our Medicare reimbursement, which would be enough to cover the debt service and other costs of putting in that hardware and software. So the idea here is through Medicare, Medicaid, and eventually private reimbursers to pay hospitals and medical practices the cost of bringing the hardware and software together to get this done. That's the solution in my mind. And, but HIPAA is not the problem. I'm a patient there too. And I'll tell you what's bizarre about it is all the Penn units have my records, the Pigment and Lesion Center for Skin and the Shea Eye Institute for my contacts and all that. But if I go across the street to Jefferson, they don't have any of it. I mean, and I would gladly sign a form that says, yeah, Jefferson can have it, or St. Peter's can have it, or St. Barnabas can have it. But they're not going to have it because they don't have the architecture to build it on yet. Yes? Mm-hmm. I don't know why corporate America didn't support single payer. I would guess the reason is that in the brotherhood of corporate America, the executives from the health insurance companies got together with the executives from the auto companies and said, hey, you know, don't interfere with our business. I think that it would be a tremendous shot in the arm to manufacturing companies in America if the retiree health costs of their retirees under 65, pre-Medicare, were supported by a more public system. I think it would take the burden off of them in a fair and equitable way and make them much more competitive in the world. Which is one of the reasons why we think that covering everyone is necessary. And because you've got a lot of 59 or 60-year-old retirees from those industries who are not on Medicare because they're too young, and whose costs are then paid by the manufacturing companies. We would think there's a much better way to do it. There was none. Because I think, you know, somebody might be the president of GM one day, might be the president of Anthem, Blue Cross and Blue Shield the next. That's not a thought that's lost on these guys. Yes? Mm-hmm. Here's what I think the viable path forward is. First of all, there is no viable path that doesn't include passing comprehensive reform, in my view. Mitch McConnell said it very well. If we do nothing, our economy is going to get a lot weaker, the problem is going to metastasize, and never mind the fact that nearly 50 million people are going to be on the verge of bankruptcy if they get sick. More than that, actually. There's a lot of people who have insurance that doesn't protect them very well. So I don't believe we can even entertain the idea of not getting something meaningful done here. How do we do it? And I'll put my sort of amateur Woodrow Wilson school hat on for a minute and say that, you know, you have to win to govern. And in order for us to win, it is important to win back some independent voters who believe that our approach to this problem has been wrong, that we've been arrogant, that we've been unwilling to reach out to the Republicans, that we are sort of know-it-alls that are just moving full speed ahead. None of which I believe is true, but perception is more important than reality. I think what the President's doing next Thursday is a very important antidote to that sickness. He's going to let anyone who cares to watch see what the real dynamic here has been. And the real dynamic here has been the Republicans saying things like I read from Senator McConnell, and then essentially following the Senator DeMint prescription. Senator DeMint is the very conservative senator from South Carolina who said last spring, we are going to, quote, break Obama on this health care issue, close quote. We're going to make his Waterloo. He explicitly said that the agenda of the Republican Party was to simply defeat the president on this issue, brand him to be a failure, and then defeat all of us in the election. There are many people who'd like to see that. I mean, you know, I understand there are people across the political spectrum who would like that result. I don't think they're the pivotal voters. I think the pivotal voters are the independents who are frustrated and who believe that we have not handled this issue very well. So I think what the president's doing Thursday is a chance to let those and other voters see what the real dialogue is, where this president has, in my view, a well-developed, reasonable set of solutions on which he is willing to be flexible and compromise to a degree, and his opposition has an inflexible, politically driven opposition. I hope that I'm wrong and that summit is a blazing success and that we come out of there with a bill that 80 senators can support that covers 25 or 30 million people and gets this problem under control. I'm not willing to discount that that's possible. I think it's very unlikely. And if I'm right, then I think that we should go to the procedure that has been used 23 times since the early 80s to pass every significant piece of economic legislation that's come out of the United States Senate during that time, which is the 51 vote rule instead of the 60 vote rule. Now, for all of these crocodile tears that are being cried about abandoning the 60 vote rule for this issue, I didn't hear that concern when the Bush tax cuts were enacted in 2001 and 2003, which were adopted through the reconciliation 51 vote rule. I didn't hear this concern in 1981 when the Reagan tax cuts were enacted through reconciliation. I didn't hear this concern in 1996 when the bipartisan agreement between President Clinton and the Republican Congress on welfare reform was enacted. On 23 occasions for major economic legislation, the 51 vote rule has been used in the Senate. I think it should be used here. And I think it then simply becomes a matter of Senator Reid determining what set of proposals he can get 51 votes for, those of us in the House deciding whether we can be supportive of that, and moving forward. The differences between the House bill and the Senate bill are significant, but by no means are they not able to be bridged. So that's what I think the future holds. And I believe me, I'm not prejudging next Thursday's events. I'm hopeful that the Republicans will do a political recalculation and realize that independent voters who are not happy with the direction of the country will be even less happy what they perceive as an explicit attempt to just block progress. But I'm not terribly optimistic that will be the result. And if it isn't, that's what I think we should do. Yes, sir. Yeah. The individual mandate, which is the proposal that says that every person will have to have health insurance, in my view, is a politically difficult but substantively necessary provision. And it is necessary for two reasons. One is that if you are going to provide decent insurance for every person, well or sick, it is necessary to have every person in the system to help pay part of that cost. That's what insurance is. The second reason, I think, is one of basic fairness. Each of us believes at some point in our life that we're indestructible. And then we grow up and find out that we're not. And there are people who will choose not to buy health insurance, who will have a car accident or a sports injury or, God forbid, a malignancy. And they will go to an emergency room and they will get first-class care and first-class follow-on care from that. And I'm glad they do in this country. And then you will pay their bill because they will be unable to. And the cost of their decision to avoid buying insurance will be spread upon everyone else who, in fact, has chosen to buy insurance. And that's a harsh political message, I hear you, but I think it's the right thing to do. I think it's only the right thing to do if there are sufficient subsidies for low-income people, however. And this is one enormous difference between the House and Senate bills that needs to be addressed. A waitress working at the Princetonian diner who also cleans houses on the weekends and makes, $24,000 a year and has no health insurance. And maybe the Princetonian provides it. I'm not sure. I don't mean to characterize it, but just any diner, any hypothetical diner. Under the House bill, she would be able to get decent health insurance for about $15 a week. I think that's quite reasonable, and although $15 is a lot of money, if you're making $2,000 a month, it's a lot of money. I think it's within that person's ability to pay. The Senate bill would have her pay a premium of about $30 a week. The other difference is that our bill would say that if you add up her premiums, her co-pays, and her deductibles, anything she'd pay for health insurance, it couldn't exceed about $900 in a given year. The Senate would have her pay over $2,000 in a given year, and I think that's troublesome for someone in that category. So this is a major difference between the two bills that has to be restored, but I think that the individual mandate, although it is a very politically difficult message to carry, is right on substance and right on the merits, on fairness. Yes? Mm-hmm. I think you're right, and I think it should be, and let me talk about how our plan does that. You're right, that there are more services being done by nurse practitioners today than there used to be, that doing some of the work physicians used to do. Now, let me say from the outset, I think nurse practitioners are incredibly competent and able to do some of that work, and I think that I don't mean in any way to impugn or criticize their profession. But I think if you want to see a physician, you should get to see a physician. I don't think it should be a choice that's made by your insurance company or by Medicare. I think it should be a choice you make. If you're happy with seeing a nurse practitioner, for example, then you should. But if you don't want that, then you shouldn't. I think that's important. Why do we have this phenomenon? 25 years ago, the typical health insurance company paid about 90 cents of every premium dollar it took in out to hospitals and doctors and providers, and kept about a dime. This is called the medical loss ratio. Today, that is more like 70 cents of every dollar paid out to a hospital, a doctor, a practitioner, and 30 cents retained by the health insurance company. Now, in order to keep those profit margins as high as they want to have them, there are two ways that health insurance companies can effectuate that result. The first is to raise people's premiums, which they do all the time. Premiums have doubled in the last 10 years. The second way, though, is to pay providers less to do whatever's covered by the policy. So the insurer very much has an incentive to say, no, you're going to get this service from a nurse practitioner, not a physician, because the nurse practitioner charges 20% of what the physician charges. What is the solution to this? I think the solution is competition among insurers, because competition will not simply be done on the basis of price, it will also be done on the basis of quality. A plan, for example, if you were to choose between two plans and one said, you will always get to see the provider that you want to see rather than the provider we direct you to. You might pay more for that policy, but you'd probably put a higher value on that. That's what you would choose. You would vote with your feet, and that's what you would do. And if you felt there was a dilution of quality, you would go to a different policy. You don't really have those choices today because most of us live in a market that is oligopolistic. The typical market concentration is 78%. That is, the top two providers in any given market have 78% of market share on the average in the United States. and they are exempt from competing with each other under the antitrust laws. So they don't compete on the basis of quality. They don't compete on the basis of price. They drive their profit margins up to a level triple what they were 25 years ago. And they make up the difference by raising your premium and by diluting the quality of what you get by paying less for it. So I think that the answer to the problem you very correctly suggest is more viable and effective competition in health insurance. Yes, sir. Yeah. 220 votes in favor and I think 215 against. Correct. Yep. Very few Democrats didn't vote for the stimulus, but yeah, we lost one. Right. Yeah, probably not. We don't want to do that. Can I tell you why? You know, we think there are three really difficult problems in the Senate bill. One, any insurance policy in existence today that permits discrimination based on a pre-existing condition, in other words, it says, sorry, we don't insure diabetics, or we raise their premiums by triple, is permanently grandfathered in. So as long as the employer keeps that policy, it never has to change. That's a very serious problem, I think, because we've been promising the American public that we're going to fix that. For 180 million people who are covered by their employer, until the employer changes plans, that discrimination doesn't change. So that's a major problem. Second problem is the one I mentioned, the gentleman about the individual mandate. The subsidies that will help modest income people buy health insurance and meet that mandate, in my view, are insufficient. I can't support saying to someone who makes $24,000 a year that they're going to have to pay $30 or $35 a week to buy health insurance. 15, I think, is a reasonable number. 35 isn't. And that's a second consideration. And the third is, this is one a little more fluid, but the Senate bill chooses to say that an insurance policy that costs more than $23,000 a year is somehow an exotic, expensive policy and in effect taxes the person who owns that policy irrespective of their income or what they do. So a Newark firefighter who gave up wage increases and perhaps some other things and got a rather generous health insurance policy would pay higher taxes on his or her policy as a result of this. I don't think that's a very good idea. So these are three flaws in the Senate bill that I think Rush would agree most of us on our side are not eager to embrace. Yep. Yeah, I'll try to be brief in my answer too. But yeah. Yeah.
How do we get there? What can possibly happen? President Obama will probably make the Republicans look silly next to the way he did and look at their conference. But that's not getting anything done.
Yeah, here's how we get there, and I'll be very direct. We have to figure out what 51 members of the Senate are willing to vote for. Not 60, but 51. And there has been some real reluctance among the Senate Democrats to be pinned down on that question. I think that next Thursday's meeting will help remove the objection that some of those senators have that, well, we haven't really reached out enough to the other side and tried to get their consent. I think that will either We'll either have that consent or we'll not have that argument anymore. And I think that would then move us to where we need to go. And I want to say this again, that I don't think all of our ideas are perfect and none of their ideas are any good. Rush can attest to this because he's done it as well. I've met personally with 8 Republican members of our committee and asked in private meetings and asked their ideas. And whenever we get to the point where we either have to impose new rules in the insurance industry or require large employers to cover people or cut some spending or raise revenue, then it's no good. Well, folks, if you don't do some of those things, you can't fix the problem. And so, I think that's how we get to where we need to go. Who had the next question? Yes, ma'am. Mm-hmm. I would have the most robust form of public option we could compete with the private insurers, and I think it would be the best way. We came very close to getting that in the House bill, and the House public option, in my view, was not sufficiently strong, but that's what I would do. I would say that basically if a hospital takes Medicare patients, it has to take public option patients, which would give the public option the ability to negotiate good rates. There'd be honest competition between the public and private. I think we'd all benefit from it. That's what I would do. No. To be blunt, I mean, I'll answer your question directly. There weren't 218 votes in the House for that proposition in November. There'd be fewer now. And I don't believe there were 51 votes in the Senate either. But I think there are 51 votes in the Senate for the changes I just talked about, the subsidies and the excise tax and the insurance reform. Yes, sir.
A couple of years ago, the Republican wrote a report on options to take for healthcare reform. And one of the items that was in there that I didn't hear on your list that I did was trying to do something to reduce extraordinarily costly end-of-life care that's not asked for and oftentimes even against the express wishes of patients and their families. And we had a proposal to deal with that through consultation with physicians, and I believe it was a Republican senator who initially championed that, and we don't know how that worked out.
Well, actually, you know what? It actually did work. Yeah, it did work out.
But so where I'm going is that this isn't a problem that's going to go away. Right?
No.
An aging population, and we're going to continue to come up with more and more expensive ways of keeping people alive as long as possible for respect for quality. And I fear that we're not mature enough as a nation to have a discussion like this. So I'm wondering if you see any hope for addressing this issue either this round or...
No, I do see lots of hope because the bill that passed the House, and if I'm not mistaken, the Senate, did what we wanted to do. It said that if a person wants to have a discussion about end-of-life care options with a doctor, with a trusted advisor, that Medicare will pay for that consultation as a covered service. What will this lead to? Well, let me tell you what it won't lead to. And even in this setting, it's very important to say this. It will not lead to any government official ever deciding that anyone will be cut off from health care and have to die. Of all the lies told in this debate, that's the biggest one, and that's the least true one. So it won't ever lead to that. Here's what it would do, though. More people would say, yeah, you know, I heard that my nephew's grandmother down the street went to hospice care. It seemed to be a very good thing. I wonder what that's about. And that a person could then talk to his or her family physician, get some counseling, how to sign up for it, how to do it. I think it would lead to increased use of hospice care at the end of life, increased use of other palliative care measures, I would call them, that would reduce end-of-life expenditures on a purely voluntary basis and be a good thing. But that's in our bill. Despite all of the misrepresentations, it survived, pun intended. And it really is one of the worst misrepresentations. By the way, we do have death panels today. They're called insurance companies. And we absolutely have people covered by private insurance who are told that there are certain things they can't get because they're too old. I mean, I was on the phone a few years ago with the CEO of an insurance company that refused to cover an organ transplant. We had a young mother, young woman in her 40s, needed a kidney transplant. And she was a breast cancer survivor. But she had not been in full remission for 5 years, which was the company's guidelines, so they were going to deny her the kidney transplant until she reached the 5-year remission on the breast cancer, which she wouldn't have reached because she would have died. So that's a death panel, everyone. But I mean, and she called us, and we called him, and sort of suggested that he change his position, and he did. But I mean, that's the reality of the situation today. That's the reality. Yes, sir. Here comes a hard question. I'm not sure I'm ready for this. Thank you, Rush. I appreciate that. Thank you. Mm-hmm. Sure. As the Congressman has said, it's very important to distinguish between the cost of the healthcare system to the economy that we pay in premiums and local taxes and out-of-pocket costs and federal taxes, and simply the effect on the federal budget. Under either of those metrics, what we're trying to do here helps solve the problem of overburdening us with debt and deficit. On the cost of the economy, there are varying views on this, but the consensus view is that something like the House or Senate bill would slow the rate of growth in healthcare inflation down by about 100 basis points a year. That is from 8.5% down to 7 or 7.5%. What does that mean? Well, in today's economy, that's 100, and it is, what is it? We have a $14 trillion economy. So 10% of that is $1.4 trillion. It's $140 billion a year. $140 billion a year in costs that we're presently spending on premiums and out-of-pockets and expenses in the healthcare system that aren't terribly productive, that could be shifted to research and development, infrastructure, tax reduction, whatever other priorities the country may have. It's an enormous shift in the economy. That's the consensus view. There are some who think that it would not reduce the cost over time. There are others who think it would reduce the cost by more than I said over time. But that's the consensus view, that it would shift about 1% of GDP each year from healthcare to something else. And the something else, you know, let me just use this analogy. What the Clinton economic plan in 1993 did, the Clinton balance, but adopted by reconciliation, by the way, what it did was to shift a significant amount of money from debt service in the federal budget to something else. The federal budget deficit went from $400 billion when that plan was voted on to a surplus of $250 billion by the time he left office. Where was the something else? It's called the internet. It's called the tech boom. It's called 23 million new jobs that got created in this economy between 1993 and 2000 because of that economic shift. That is the potential, I believe, of this as well, and I think it's the reality of it. As far as the budget deficit is concerned, this Congressional Budget Office, which is a neutral, nonpartisan referee, says that the House bill will reduce the federal deficit over the first 10 years by about $110 billion. And over the second 10 years, it will reduce the budget deficit per year, an average of 0.5% of GDP to a full percent of GDP, $70 to $140 billion a year in present terms. So, you know, this is very significant. Here's what I think we've done a very bad job of explaining, and I'll take full responsibility for this myself. When people stand up and say, this plan costs too much, the issue is compared to what? What costs too much right now is the 22% increases in health insurance premiums that small businesses are facing. What costs too much now is the hundreds of millions of dollars of care that New Jersey hospitals are providing and not getting paid for because people are uninsured. So you pay for this. Everyone who pays insurance premiums or state and local taxes pays for this cost right now. The issue is whether it can be shifted away from them to a more rational and sensible way to do this. I think we have time maybe for one more. And yes, sir. It's my privilege. Mm-hmm. Glad to hear that. Mm-hmm. Yeah, you would love to have, yes. First of all, let me say thank you for the choice that you're making. It's heartening to hear a person of your abilities make that choice, given what you're giving up economically. I truly appreciate it. And second, let me say that I know that you're not simply motivated by money. Obviously, you wouldn't make the choice that you're making if you were, but I don't think any physician is motivated by money solely, or even principally. Most people I know in the healing professions are there because they really do want to make a fulfilling and meaningful contribution with their life. And so I'm not about to say that money is the only factor. However, the House bill does three things that I think would address the concerns that you've raised. First of all, it has significant opportunities to reduce your loan burden if you choose primary care. In a case like yours, if the House bill became law, you would have up to about half of your student loan debt written off if you made a 5-year commitment to primary care, which you're doing. So that's one enormous plus right off the bat. Second is we are expanding the number of seats in medical schools directed to primary care. As you know, the way medical schools typically get federal assistance is through what's called graduate medical education rates at teaching hospitals. Those provisions are tilted toward more primary care seats and more medical schools, which I think will be beneficial. And then third, and I think this is the single most important thing, Medicaid, which is the program that covers very low-income people, right? So a child whose mom is a custodian who makes $20,000 a year, that has a couple of siblings, is on Medicaid. Mother isn't. She's uninsured. But the child's on Medicaid. Right now, it's impossible almost for that mother to find a pediatrician who will see the child because the pediatrician will get $6 a visit or so to see the child. So what a lot of pediatricians do is see the child anyway for free because the cost of processing the $6 claim isn't worth it, but a lot of physicians won't see the child. The House bill for Medicaid increases reimbursement rates for primary care providers up to about $40 or $45 a visit. In other words, what a doctor gets to see a Medicare patient. Now, the benefit of this is that we think that, Rush, I'll see you tomorrow. The benefit of this is that we think that more primary care providers would get, frankly, a better income for seeing lower income kids that are on Medicaid. Let me just conclude by saying thank you, Dean, again for this opportunity. I'm honored that my friend and colleague came to. It's great. Look, this is a very difficult problem. And I do not by any means want to imply that we think we have all the answers, the other side has no answers, and they're all wrong, and we're all right. But I don't want to get caught in this trap either. It's become axiomatic in American politics to say, healthcare is a very complicated problem, and we really have to keep studying it, and no one really knows what to do. Well, I don't know what to do. But I have some pretty strong opinions on what to do based upon working on this issue and listening to thousands of people who are doctors and nurses and insurers and educators and moms and dads trying to pay their bills. And I think what we have to do is pretty simple. We have to make the insurance industry compete the way everybody else does in American life, with the same ground rules. We have to get everyone insured in this country so we don't have this shift of cost from the uninsured to the insured. And we have to pay for it by providing meaningful subsidies for people to get insured, paid for by progressive means of raising revenue and by cutting wasteful medical outlays. That's what I think. And you know what? That isn't going to change. There's not some magic healthcare solution that's going to drop down from the sky. The reason I sort of soft-pedaled wellness at the beginning, I love the whole wellness idea, and I hope that 20 years from now, every kid's an Olympic quality athlete and very fit. I really hope that happens. But it lets people off the hook to say that that's the solution. You know, let's have the NFL encourage kids to play 60 every day. Well, that's great. But, you know, if the kid has asthma and can't see a pediatrician, it's kind of hard to play 60 minutes. And let's have everybody get encouraged about, you know, new models of care delivery. That's a terrific idea. But if you're 52 years old and you work at the Home Depot 20 hours a week and can't buy insurance, that does you no good whatsoever. It's not some deep papal selection mystery how to get this problem solved. It just takes some political will. And I'm proud that, you know, myself and my friend and a bunch of us exercised that political will in November, and we want to do it again. We do want to do it again. I want all those that are listening tonight to think that somehow the cause has drifted, to understand we haven't drifted at all. And we're looking for the right way to get this done because we understand what a high responsibility it is. Thank you very much again for this opportunity.